Physical Therapist Assistant Program. She taught Introduction to Physical Therapy procedures, therapeutic exercise, musculoskeletal dysfunction, and geriatrics. Currently, Laura is the owner and manager of Apex Physical Therapy in Belpre, Ohio. Her current clinical focus is the management of spine and orthopedic conditions in an outpatient setting with a special interest in treating headaches. Laura has a history of spontaneous intracranial hypotension, so I think you'll enjoy her talk.
Hello. Okay, so can everybody hear me? All right, that's going to be a hard act to follow. I do have some video in my presentation, but nothing as cool as Garth Brooks. So I am really excited that rehab was included in today's symposium because, first of all, I am a physical therapist, so I'm a little biased here, but I think rehab is obviously very important. And also because as patients, we all know what happens. So as we go through this journey, we just spend months, maybe years, some of you, trying to just find a diagnosis, trying to figure out what on earth is going on here. Then once we finally get a diagnosis, I don't know if any of you felt this way, but I turned into a walking, talking, researching machine, right? I was going to solve this problem single-handedly. So after our research, we decide on a clinician, and we put a lot of time, resources, and hope into a procedure to hopefully correct this problem. And then we're discharged home to walk on eggshells and hope I don't screw anything up, right? And so that's why I'm here today, really to talk about the now whats, right? All right, so a little bit of background about myself. I used the word we in the previous slide because, like many of you, I do have a history of a intracranial hypotension. And as you can read here, I am a wife. I married my best friend in 2001, and then I started leaking in 2003. And since that horrible day, when I started leaking, not when I got married, my husband and I have been through a lot together. We have had 2 children together. We've been through 5 spine surgeries, and we have opened a practice together in outpatient physical therapy. So like many of you, I have been through a lot, but I have chose to learn from my experiences and to use my insight to serve others. I really feel like seeing healthcare through the eyes of a patient has helped me to transform into a better clinician and help those patients that I serve in physical therapy. Okay, so we got some really cool information earlier today about the treatments for CSF leaks. But I am here today to focus on the aftermath. So I'm going to talk about some precautions, some guidelines, and some recommendations after you've had a patch or after you've undergone surgery. So the first question that I like to ask is, what does the research tell us about physical therapy or about rehab? Does anyone have a guess to what the answer to that is? Not much. Not much. There's not a lot of data out there from a rehab perspective. In fact, as I was researching it a little bit, this isn't even a topic that is addressed in the physical therapy curriculum. So it is definitely a topic where I would like to see more research done in the future. The problem with that is geography. So we know that as leakers, we are located all over the globe, but it's hard to get a group of people together in a common location for an extended period of time to have a control group and to have an experimental group to then get good experimental data. So from a physical therapy standpoint, we don't know a lot about how to treat these patients. But let's look at what we do know. Okay, so we do know the normal phases of the inflammatory process and what to expect during healing. So if there's any of you out there with a medical background, this is something we learn in school, the inflammatory process, and then we immediately try to tuck away and forget that it ever happened because it's a very complex, very, very complex problem. But no fear, I am going to summarize it for you in 3 simple slides. Okay, so during the inflammation process, we have the inflammatory phase, which is going to prepare the wound for healing. We have the proliferation phase, which is going to rebuild damaged structures. And then we have the maturation phase, which is going to modify scar tissue into its mature form. So during the acute phase, which is generally the first 2 days, what are we seeing? We are going to see some of those hallmark signs and symptoms. We're going to see heat, swelling, redness, and pain. So some of the things that you're going to see immediately after a patch or immediately after surgery. Okay, so the heat and redness is going to occur because there is increased blood flow into the area. There's going to be increased swelling because of increased vessel permeability. And you're going to see increased pain because the swelling is going to compress pain-sensitive structures. And then finally, we're going to see blood clot formation within the first 2 days. So from a rehab perspective, we treat patients with those cardinal signs and symptoms with what we call the RICE acronym, which stands for rest, ice, compression, and elevation. Okay, so for days 2 through 4, we're going to see that the inflammation starts to subside. We're going to see reabsorption of the clot and an increase in granular tissue, or that new healthy tissue is starting to form. So between days 4 and 21 of healing, the patient's going to be in the proliferation phase. And what's happening here is we're going to start getting scar formation. The wound is going to become covered, and the wound is going to start to actually regain some of its strength. So in fact, scar tissue is initially made up of a thin and weak collagen, but by day 12, it's replaced by a stronger type of collagen, which is good. And then finally, new vessels are formed. And these vessels are initially really thin and weak. So it's good for us to know as physical therapists that for the first 21 days, we're going to be really gentle and really cautious with our manual techniques during that time frame. So finally, the maturation phase is the longest phase in the healing process, and it can exist for up to a year after the injury. And during that time, the scar is going to get a little bit wider as the collagen matures, and the collagen will get thicker and stronger. So what do we know specifically about dural patches or repairs? Okay, so we know based on what we just learned that the tissue healing, we want to allow time for that healing and scarring to occur. We know that we do not want to strain, stretch, or shear weak dural tissue. And we know that if we increase intra-abdominal pressure, it can increase intracranial pressure, which could damage our healing repair. So let's go on a journey together. Okay, you guys have just had a patch or a repair. What are some of the things that we know may happen? We know that you may experience some pain. We know that you need to communicate your needs with your healthcare provider. A lot of times after you have an intervention, your medical team has a really good idea of what symptoms or problems to expect, but unless you communicate your needs, they cannot intervene appropriately. So you really have to have that open line of communication. We know that you may be encouraged to lay flat. And that duration is going to change from clinician to clinician. And we know that you may be issued precautions. So let's look at some of the common precautions. So after a surgery or a patch, these are some of the things that we want to consider. We want to avoid the BLT, the bending, lifting, or twisting. So what does that specifically mean to you? It means you need to think basically before every movement that you make. Okay, so you need to think about when you're brushing your teeth. How am I moving? You need to think about when I'm picking things up. How am I moving? Something as simple as how you're sitting to read a book, you need to consider, okay? We know that you need to keep your back straight and try to not bend from your knees. You need to bend from your knees and keep your back straight. And I actually have a slide later that shows like proper bending techniques. So we'll talk about that. We know that we need to face our objects directly that we're working with to avoid twisting. We need to sit using correct posture. So I also have a couple of slides that recommend what that correct sitting posture is going to look like. And we need to maintain your weightlifting restrictions. Every clinician, again, is going to have different recommendations based on your specific needs as far as your lifting recommendations. And finally, actually there's two more. You're going to use a pillow between your knees when you are laying on your side. I also have a slide later to show what this is going to look like. And we're going to avoid prolonged static postures. So another thing that I'll mention is when you are discharged from having a procedure, really just pay attention to your discharge recommendations. So when I was a patient at Cedars, the physical therapy team and the occupational therapy team, they really did a good job at giving me discharge recommendations and talking to me about my precautions. All right. This is where my fun video kicks in. So we're going to go on a journey. We're going to assume that I was just discharged from the hospital. And for sake of ease, we're going to assume that I don't live on the other side of the country, that I have a local commute. And I was given some discharge paperwork, and now I was wheeled down to my car, and now I need to get in. But how do I do that without violating my restrictions? So this is what I'm going to do. I'm going to stand facing away from the seat. I'm going to reach back to ensure that I am in contact with the seat. And I'm going to keep my spine straight as I pull my legs into the car. And of course, I'm going to finish with a cheesy smile. Right? I do that in every slide. Cheesy smile. Okay. So I'm sure a lot of you have recommendations about travel. But for me, traveling in the car was pretty brutal, not very fun. So my recommendation was to take a thin pillow to have, because thoracic sutures and leather seating are never a really good combination. Okay, so now that I survived this commute home, which is probably what I perceived to be the most brutal car ride ever, even though my husband was very cautious, it's time to get out. And if you guys are anything like me, you have 2 or 3 people staring at you, trying to figure out how to get you out of the car and inside. And this is how it should be done. So you're going to keep your spine straight. You're going to move your legs out of the car, scoot to the edge of the chair, and slowly stand up while keeping your back straight. And then my daughter wanted me to make a silly face. So I've clearly had a big day already, and I'm exhausted, and I just want to lay down and rest. How am I going to go from standing up to now sitting down safely and without violating any restrictions? I'm going to reach back and make sure that I feel my sitting surface, which I did, and then I'm going to keep my spine straight as I slowly lower myself onto my bed. The key point here is that you do not bend forward at the trunk or in my spine. And now I'm going to lay down and take a nap. So I need to go from standing to laying down. Okay, so to go from standing to laying down, because I'm clearly exhausted, I look exhausted, I'm going to make sure I feel my surface. I'm going to slowly lower myself as a unit, going to bring my legs up into the bed, and then slowly lower. Okay, so that was a log roll technique. As you notice towards the end there, I brought both legs down at the same time, and that can increase the strain, okay? So I'm being critical of myself here. That can increase the strain and thus increase my intracranial pressure. So something that I could have done differently is just bring one leg down at a time, and that would have created less strain. Okay, so if I'm just going to be moving in bed, you want to log roll without twisting your spine. So this is just me staying stiff like a board to log roll. Okay, so after the first couple of days, I really don't want to leave my bed often. I mean, look at it, who would? I've spent a lot of time here. But some people tell me that nutrition and hygiene are important. So I decided to get up, right? This is how it should be done. So I am going to log roll onto my side. I'm going to drop my knees over the edge of the bed. And then as a unit, I'm going to sit up, okay? And once I'm there, I always like to just sit for a minute to make sure that my body has had time to adjust to my new orientation in space so I don't get dizzy when I decide to go ahead and walk. Okay, standing up from sitting. This is pretty self-explanatory. I'm going to move to the edge of the bed. I'm going to ensure that my back is straight, and I'm going to stand up pushing through my arms. Okay, so what if we want to pick something up from the floor? I'm going to show you 3 different techniques for picking something up from the floor, okay? So the first one is using a reacher. I highly recommend purchasing a reacher. It's been a game changer for me. I think you can get them for like $10 to $15 on Amazon. You want to get one that has a really rubbery grip to it. But this is the first video with using the reacher. Okay, so notice that I am keeping my spine still nice and straight and finishing with a smile. Picking up pillows is really fun. The second technique is the traditional squat. So I'm getting as close to the object as possible, keeping my spine straight, bending with my legs. Okay, and finishing with a smile. The last technique is a technique called the pivot technique, and I don't really recommend it immediately after surgery or for patients with balance issues because you have to maintain your balance while on a single limb support. So you're going to bend forward and you are going to lever. Notice I still have a straight spine and am happy to have picked up a pillow. Now, if any of you are that excited about picking things up from the floor, I have a playroom at home that could use some work. You can just meet me afterwards. Okay, so if you wash your face, the gal in the left picture, she's doing a wonderful job at maintaining her restrictions. The gal in the right picture, not so much, right? So if you're washing your face, you're going to use 3 washcloths according to the literature, unless you're green, environmentally green. But for the 3 washcloths, you're going to lather one of them with soap. You're going to use one that is clean but wet for rinsing and one for drying. The key factor here is that we do not want to bend forward. What about if you're brushing your teeth? I like this slide because I get to use the word spit. Okay, so for this slide, when you brush your teeth, you are going to have 2 cups. You are going to have one for rinsing, and you are going to have one for spitting, okay? So we're going to put your toothpaste on your toothbrush, and you're going to brush your teeth, okay? Then you're going to take your spit cup and spit into it. Then you're going to rinse your mouth out and spit again into the spit cup, okay? This keeps you from violating your bending restrictions. And I think it was my 4th surgery before I processed this and actually did this right. So I think I was actually the girl in the right slide for my first 3 surgeries, but don't tell anyone. Okay. Okay, what about bathing? Okay. We like the idea of using a shower. We don't like the idea of getting down into a bathtub. I've tried it several different times, and I just have not been able to figure out how to get down into a bathtub without violating those bending, lifting, twisting restrictions. And plus, I also think getting into a bathtub in this long sitting position puts a lot of strain on your dura, so it's just generally not recommended. Showering is preferred. Okay, so let's say that you were able to maintain your initial precautions, and now you've been referred to physical therapy, okay? So back in 2015, there was a group of clinicians that collaborated. We got together and we talked about what we wanted to see with a physical therapy program. So I would like to thank a few people for helping me to establish these guiding principles. So we worked with Jennifer Schoon, Jane Barsick, Alyssa Weigand. I have a friend and colleague, Anne-Marie Lowers, and of course, Dr. DeLine was helpful with us. So some of those things that we agreed upon. We want to avoid activities that cause dural tension. We want to avoid joint traction and distraction. We want to avoid joint mobilizations around the injection or surgical site. We want to avoid deep myofascial release or massage around the injection or surgical site. When you're strengthening, you don't want to hold your breath. You want to avoid the use of machines for exercise. You want to avoid rotational core stabilization exercise. You don't want to have an increase in your amount of headache as you're exercising. You want to avoid the use of force when we're trying to do range of motion exercises. And we want to avoid sit-ups. So let's talk a little bit more about those guidelines. So our first recommendation was to avoid activities that cause dural slide and glide. So what exactly does that mean, right? To answer that question, I want to show you 2 dural tension tests that are frequently performed in physical therapy. One reason that I might use this test is if someone had a disc bulge that was maybe compressing against a nerve root. So this is a provocative test that has been shown through research to place tension on or stretch the dura. So the first one there is the straight leg raise test. To perform that test, the patient is going to be laying flat, okay? The leg is elevated and the knee is extended, which is going to produce strain on the sciatic nerve and create traction on the nerve roots of the lumbar spine. We can make it more provocative by flexing the neck, dorsiflexing the ankle or bending it towards the nose, and medially rotating the hip or bringing it towards midline. So that will increase the amount of tension. By the show of hands, how many of you have been in this position within the past week? Okay. So these are some of the activities in real life that might actually mimic that provocative test. One of those would be shaving in the shower, right? I'm pretty much in that same position. So this would be something that you would want to avoid initially. The second one would be hamstring stretching. Commonly, during physical therapy, you're going to be asked to do hamstring stretching, right? And this would be something that you would just tell your therapist, like, that's probably not the best plan for me, and kindly decline that request, okay? And then the last one would be bending incorrectly to retrieve an object from the floor. Those would all be provocative and strain your dura. Okay, the second one would be the seated slump test. So for this test, we're going to assume a position of full lumbar and thoracic flexion. So in other words, I'm getting slouchy. I'm nice and slumpy. Okay. To make it more provocative, we're going to bend the neck. We're going to straighten the knee. We're going to dorsiflex the ankle and internally rotate or bring the hip towards midline. How about this position? Has anyone been in this position in the past week? Okay, I guarantee you have. Okay, so these are some common activities that might mimic that seated slump test, okay? So we have our seated hamstring stretch. This is the immediate go-to for a physical therapist. So if I'm thinking hamstring stretching, I'm thinking seated hamstring stretching. This is the first type of hamstring stretching I would try to do with you in the clinic. So you want to make sure that you're not doing that in physical therapy. What about if I'm just sitting in my recliner with my feet elevated? Yeah, so I'm in a long sitting position. I've got my head slouched, right? Got text neck going on. So this is also a position then that might put strain on your dura. Okay, pretty common position. What about sitting in a bathtub? Okay, that's why we prefer showering. And then lastly, long sitting in a bed. So a lot of you kind of take the load off at night, sit up in your bed. Anytime you're in that long sitting position, you could be straining your dura, okay? So we talked a little bit about the positions you should avoid, but what positions is preferred? Where should you be? This is the preferred sitting position, and I'm smiling so big in this picture because my dura is happy. Yeah? Okay, so in this position, I have a kind of firm back support. If you are sitting in a recliner, I tell my patients this every day, a recliner will eat you, okay? It's really too cushy, and it will put you in a flexed posture. You really need something that's gonna help you maintain that upright posture. Your hips should touch the back of the chair. Your feet should be touching the floor. And I also have a lumbar support there, supporting that natural curvature in my spine, okay? So if you look at my posture from the side, you should see a straight line. There's a pointer here somewhere. You should see a straight line going down straight through my ear, my shoulder, my spine to my hip, okay? What about my sleeping position? Okay, so in this first picture, I have a pillow underneath of my knees. By putting a pillow under my knees, this is where I like to move. Can you still hear me? Yeah. Okay, if I have a pillow under my knees, then it's automatically going to make my pelvis go into a posterior pelvic tilt, which is going to remove some of that bend in my spine and make it a little less straining. Okay, does that make sense? I'm going to be critical of my picture here again. Can anyone figure out what I don't like about my picture? My neck. My neck is in a horrible position there. That pillow is way too big, and I have way too much flexion. So if my spouse looks at me from the side, I should have a pretty straight line, again, from my hip all the way up to my head in that sleeping position. The second position there is in side lying. So I don't know, I'm kind of in a white cloud of happiness there. But I have two pillows in that second picture. The first one is between my knees. So by having that between my knees, it's preventing me from, I'm going to come back over here, it's preventing any lateral flexion of my spine, okay? And I also have a pillow underneath of my top shoulder, which is preventing rotation of my spine. If you look at the pillow that's under my head, once it's compressed, it should take up the space from my ear to my shoulder, okay? So again, when my hubster or those cute little kids of mine look at me from the back, I should have a nice straight line going down my spine, okay? Okay, the second point is that we're going to want to avoid joint traction or distraction. So traction is a tool that's used in physical therapy to separate joint surfaces and elongate soft tissue. So basically what we're doing with our patients is we're strapping them in onto a table, and then their head is either strapped into a harness or their lower extremities are strapped down with belts. And then I live in West Virginia, and I practice in Belpre, Ohio. So I was explaining this to one of my patients the other day, and after getting consent, he said, so what you're going to basically do is you're going to use a human winch on me to separate my spine. And I stood there and scratched my head and said, yeah, that's pretty much what I'm going to do. So it's actually been very effective for patients that have disc bulges or disc derangements. But what about us? Do we want to elongate our dura? Do we want any kind of movement in our spine after a surgery? No, this should be definitely contraindicated and avoided, okay? What about joint mobilization? So a joint mobilization, by definition, is a skilled manual technique applied to joints at varying speeds and amplitudes to decrease pain and increase joint capsule range of motion. So generally, when it's been a significant amount of time after surgery, as a physical therapist, we'll go in and we will assess each vertebral level to see if there's equal movement at each vertebral segment. In those areas where we find hypomobility, that might be somewhere where we'll want to mobilize that joint so that overall we're going to get increased spinal movement, spinal flexion, spinal extension rotation. This is also something that should be an absolute contraindication for us. We do not want any mobilizations. So if a therapist tries to do so, we would again kindly decline that request. Okay, we're going to make sure that we are not holding our breath. Do any of you think that you would hold your breath during exercising? I see this every day. People are so bad at this, at holding their breath. If we hold our breath, it could increase our intra-abdominal pressure and lead to increased intracranial pressure, which in turn could damage our repair. So a strategy to avoid doing that is to always make sure you have a pattern for breathing when exercising. If I was doing like a bicep curl, during the contraction phase, I would blow out and then make sure I'm inhaling while I relax. Right? Okay, so we're going to avoid using machines. Machines force us to strengthen muscles in unnatural planes of motion, which I don't like. So let's think about some of the machines that you see in any gym. When was the last time in real life that you put your arms in this position and moved like this? Probably never, right? Or when was the last time you laid on your stomach and bent your legs behind you? Probably never. So we prefer strengthening with combined movement strategies. Another problem with using machines is you're often strapped in, and if you fatigue, then you lack the control to get out of that machine. So it can really be a safety issue, okay? You have much more control when strengthening against gravity, your own body weight, or TheraBand. The therapist should avoid using force to increase range of motion. So basically, we don't ever want stretching to be passive. This should be something that the patient is actively doing and only in mid-range. Okay, more video, fun. And I'm gonna be smiling, I guarantee it. So in the first video here, we're gonna talk about avoiding sit-ups. In the first video, I'm going to be doing a sit-up, which can increase that intra-abdominal pressure. And the second video it's a preferred technique, which is a pelvic tilt, which I'm able to continue to breathe during that technique, and I'm not seeing such great range of motion. So first video is my sit-up. Notice the amount of strain that you see with that technique, and also I'm violating my bending, lifting, twisting restrictions. The second one, I am getting an abdominal contraction. So I'm getting abdominal strengthening with this exercise, but I'm not violating a precaution as long as I continue to breathe appropriately. So here is the physical therapy guidelines for your physical therapist once you have been referred to therapy. The goal of phase 1 are to ensure the patient is safe and independent with their activities of daily living and instrumental activities of daily living. Basically, as a physical therapist, we want to make sure at this point that our patient can walk, transfer, bathe, feed, and toilet without help, all the good stuff. Okay? Then we want to decrease inflammation, pain, and muscle guarding. We want to decrease local sensitivity. We want to minimize deconditioning, and when we put this together, we talked about a 10-pound general lifting restriction, but again, your clinician is going to be the best person to make those recommendations based on your specific needs. So what can we do during that phase 1 protective phase as your physical therapist, as your clinician? We're going to basically provide you education about your ADL limitations or modification that you can make. We can use tools to decrease your inflammation, pain, and muscle spasm, such as ultrasound, electrical stimulation, or the use of ice. We can perform a gentle massage during the appropriate phase of healing to decrease muscle spasm and to desensitize the area. And we can begin either a treadmill or a ground-based walking program. Some people are just not candidates for the treadmill, take it from me. And then finally, if someone continues to have surgical site pain, we can prescribe a TENS unit to manage local pain. So what does our patient need to do to progress to phase 2? They need to be compliant and independent. All right, so what are the goals for phase 2? We're going to continue to address any residual pain or muscle guarding. We're going to advance aerobic conditioning, and we're going to initiate gentle range of motion, remembering not to be forceful. And then we're going to introduce unresisted postural stretching and strengthening. We're going to maintain 20-pound lifting restrictions, and again, this is just a generic number. You want to follow your surgeon or interventionalist's guidelines. So what is the therapist doing during that time? We're going to continue to use our tools to address inflammation, pain, and muscle spasm. We're going to continue gentle massage for scar desensitization. We can progress aerobic strengthening, and we can introduce stretching and strengthening progression. Now, this is going to be the point in time where we really want to trust our clinician and make sure that they have a really good idea about what exercises are safe for dural tension and what are not. So we're going to play the safe or unsafe game, okay? Let you guys try to figure out some of these exercises and whether they are or are not safe. So if I have a chair here, okay, and I'm told to stretch, can any of you see? Everybody see? Am I safe or unsafe? Unsafe. Unsafe. That would be a no-go. What about a standing squat? I'm told to stand here to make my stomach muscles tight and to slowly squat down and come back up. Safe. Safe. I could do that. I would be comfortable with that. Okay, what about a long arc quad? Okay, so this is to build the strength in my leg. I'm told to sit here and straighten my leg out in front of me. No. Not safe, right? That's gonna stretch my dura. What about standing hip flexion? What if I'm told to stand here and lift my leg out in front of me? No. Yeah, that one's questionable because during our normal gait pattern, we have some degree of flexion. So as long, I would say as long as we don't go too far, then it would be okay. But you wouldn't want to go too far with that stretch. And then finally, what about if I stand here and bring my leg out to the side? What if I'm told to do that? Safe? Unsafe? Safe. Safe. So that's just where we start thinking and really making sure that our therapist understands those dural tension restrictions. Okay, so some criteria to progress is basically, again, that they're independent and compliant with their HEP stands for home exercise program. We want to make sure that they're independent with their own pain management techniques. The goal would be that you could perform 20 repetitions of each exercise without exacerbating any pain, without making your surgical site pain worse or your headache worse. We want you to be able to walk for 10 minutes without exacerbating surgical site pain or headache, and be able to demonstrate proper posture alignment with sitting or other positions. Okay, so goal 3. Phase 3 is about finally returning to normal, getting back to our normal life. Yay! So during this phase, we're going to advance aerobic conditioning. We're going to slowly wean from our lifting restrictions. We're going to progress strengthening. We're going to do a lot of education about body mechanics during functional tasks and returning to work. And for some people, if they have more high-level demanding jobs, they might need to do a work reconditioning program. So what is your therapist going to do during that phase? So again, we're going to make sure that you are aerobically conditioned. Okay, we're going to advance your strengthening and stabilization to incorporate external resistance if that is appropriate. Again, not using machines, but using gravity, your own patient weight, or exercise band. We want to provide education regarding posture or ergonomics. So this is where if you have a secretarial job, we would want to look at your ergonomic, your workstation, and make sure that you're not going to be doing a lot of bending, to make sure that you're going to have the safe sitting mechanics, those sort of things. We're going to provide education about correct lifting mechanics, and we're going to initiate work simulated activities such as pushing, pulling, lifting, carrying. Basically, the goal is to make sure that you're returning back to your normal functions safely. Okay, so what's the criteria for discharge from physical therapy? That you are independent with your home exercise program, that you can manage your pain independently, that you can perform all of your exercise without pain or without exacerbating your headache, that you can do 20 minutes of walking without exacerbating anything, that you do have good posture without needing cueing from a therapist, and that you can do work simulated activities without causing a headache or without causing surgical site pain. Okay, so last slide, the restrictions debate. This is a question that I get a lot. So you've been through physical therapy and you've been discharged from physical therapy. What kind of long-term restrictions am I going to have? This is a question that I really don't like to answer. I don't like to group us into a box because we're all different in so many ways. We have different mechanisms of injury. Some of us come from a connective tissue disorder. Some of us don't. We have different prior level of functions. We have a different type of repair. Some have comorbidity. You know, some people have different problems coming into that, different ages, different nutrition. So I think Connie alluded to this earlier, Dr. Deline, that you really just want to work with your therapist to come up with those guidelines of what I can do now, who has specifically worked with you. Okay? So that's it. Dr. DeLine wants to come back up, and we'll take a few questions.